Welcome to Breakthrough. Today we're going to be discussing the AutoCart technique for the treatment of symptomatic cartilage defects with Rachel Frank from Denver, Colorado, and Brian Cole from Chicago, Illinois. Thank you for joining us today.
Thank you, Chris.
Great to be here, Chris.
Now let's do something a little bit different here. We're going to have some fun going through some rapid fire tips and pearls. Now, Brian, starting with patient selection, who's your ideal patient?
Chris, obviously patient selection is critical. So historically there were patients who would do well potentially with debridement, but moving forward, neurostimulation was a great option for these patients. So patients who have defect size, maybe 2 to 4 square centimeters with intact or slightly involved subchondral bone, first-line treatment. These are patients who make excellent candidates for AutoCart. These are the patients who historically maybe didn't do well with neurostimulation, but now that we have an adjunct with orthobiologics, with a matrix, and with viable chondrocytes, we think this is something that will evolve it to providing a sustainable solution based upon what we know in our current evidence.
Thank you, Brian. Now, Rachel, what about the position of the patient? Do you have a preference, and does it even matter?
Great question, Chris. Like with all surgery, patient positioning does matter, and it can either make or break your case. With respect to AutoCart, we position the patient as we would for any knee arthroscopy, and then it depends on where we're performing the AutoCart transplant and if we're doing concomitant procedures. Typically for AutoCart in the patella or the trochlea, we have the patient supine with the leg out straight, and we can get good exposure that way. And we can perform a concurrent tibial tubercle osteotomy if needed. For the distal femur, we typically have the patient supine, but with an ability to flex the knee, either using an ACL positioner or an other standard leg holder. And again, we can do concurrent procedures such as osteotomies or meniscus transplantation if needed.
Rachel, do you have any additional thoughts on the use of thrombinator at the end of the procedure?
Well, I think thrombinator is a nice adjunct to what we're doing here. As mentioned by Brian, we're underfilling the defect slightly with the AutoCart, and then we're sealing this with autologous fluid. And this autologous fluid is robust. It's got growth factors. It's got platelets. It's got all the things you need from the patient to seal the defect and really create a biologic response for healing. So you're not just sealing, but you're also healing.
Yeah, and the other thing is that it permeates the material. We know that, so it creates a much more gelatinous consistency. In addition, from our benchtop testing, we know that use of the thrombinator is equivalent to any other source of sealant that we've used in the past.
Now, Rachel, can you please discuss the value of concomitant procedures with the AutoCart technique?
Well, Chris, I think this is such an important point. For all aspects of cartilage restoration, we have to understand the concurrent pathologies. If you simply treat the cartilage but ignore relevant concurrent pathologies by not doing concurrent procedures, you may have suboptimal outcomes following the cartilage restoration. So we've got to be looking at the cartilage, but also the subchondral bone, meniscus status, alignment or malalignment, and ligament stability. If we can address the relevant problems, the cartilage restoration itself will become a better result for the patient.
That's a great point about concomitant procedures and a great segue to talk about rehab.
So rehab, I think, is dependent upon a number of variables. But what I will say is that when we are doing concomitant procedures, sometimes that drives the rehab as much as the treatment of the cartilage defect itself, right? So in general, patellofemoral lesions without tibial tubercle osteotomies can be weight-bearing as tolerated initially. And that goes a long way from a patient acceptance perspective. Tibial femoral lesions, whether isolated or with some concomitant procedures, will often undergo a period of protected weight bearing. And most of us are in the neighborhood of 6 to 8 weeks, generally not longer than that and not considerably shorter. With respect to range of motion, we generally encourage range of motion very early after this operation. So brace off, range of motion, CPM, if it can be provided, can be very beneficial. The hard part for the patient is really the first 6 to 8 weeks. And beyond that, I think decisions related to return to sport, higher level activities before that are generally guided not only by the cartilage defect, but as we said, the concomitant procedures.
Okay, so what about an isolated AutoCart procedure?
Yes, so patellofemoral lesions, that's the easiest in my opinion because that patient can be in a brace initially. There's very little contact across the patellofemoral joint if you load it. So keeping patients non-weight bearing in my mind doesn't really make a lot of sense, not supported by the biomechanics. So immediate weight bearing but immediate range of motion is allowed for patellofemoral. But as I mentioned, for tibial femoral lesions that are isolated, we still may protect their weight bearing for upwards of 6 to 8 weeks. But beyond that, they enter into more aggressive aspects of the protocol.
So, Brian and Rachel, let's close out this episode with your personal cartilage algorithm and where the AutoCart procedure best fits in.
I think, this sort of highlights the selection that we talked about before. Patients who might not otherwise be a candidate for debridement are entering into this cartilage repair pathway, right? So generally slightly small to mid-sized defects in active patients, consideration for all the comorbidities that Rachel talked about, can be candidates for marrow stimulation with an adjunct such as AutoCart. So that's really the ideal population. Then there's this mid population with small isolated defects, say 10 to 11 millimeters, who I think really there's a dominant treatment decision to be made towards osteochondral autograft. And moving forward, larger defects, revision situations, with concomitant procedures, any tibial disease or bipolar disease, those patients may be excellent candidates for an osteochondral allograft. So that encompasses in general, there's no cookbook approach, but what we've learned from our outcomes, that's a reasonable common sense approach to treating defects by size and patient demand level and those who have concomitant problems.
And I think, Chris, to add on to that, because I completely agree with the algorithm, the AutoCart technique really has improved our ability to offer more to more patients with defects. So the AutoCart procedure can be performed patella, trochlea, tibia, and distal femur, but it can be performed in large defects, small defects. It's typically arthroscopic in many cases, single stage, autologous, and cost-effective. So we're using the patient's own biology, and this is a resource that we haven't necessarily had in the past for this type of surface-based cartilage restoration technique. So AutoCart is in that algorithm that Brian mentioned, but it serves a huge role for our patients.
That was wonderful. Rachel, Brian, thank you both again for sharing your lessons learned. I'm sure these tips and pearls will help surgeons all around the world in adopting the AutoCart technique to become safer and more efficient. Now, to learn more about the AutoCart technique for the treatment of symptomatic cartilage defects, be sure to visit jointpreservation.arthrex.com and tune into our other breakthrough episodes, including innovative solutions, technique play-by-play, and making the case. Thank you for joining us.